Okay, welcome to the Deuk Spine Institute live broadcast. And Henry,
Yes,
when
sir.
you take the fluoro feed, you're not seeing the patient's name, right?
No.
Because there are new fluoro machines. I want to make sure that that's not happening, okay?
Currently, we are not. No.
Just make 1,000% sure,
Copy that.
since there are new fluoro machines. So welcome to Deuk Spine. It is March 28, 2023. I'm Dr. Ara Deuk-Majan, CEO and founder of the Deuk Spine Institute, here with my team. This patient we're doing procedure on today is a thoracic procedure. They have a thoracic spine problem. He injured his spine flying in turbulence and now has injuries to the facet joints, that's FACET joints. The facet joints are the joints between vertebrae in the back of the spine. There's a left and a right. And in his case, he has pain emanating from the facet joints on the left side. Now, the facet joints in the thoracic spine have ribs coming out of them, not out of the joints, but next to the joint. So my job is going to be to identify the proper joints, which are going to be the T5-6, T6-7, T7-8, T8-9, and to treat the nerves above and below those facet joints. We're going to use the X-ray machine to do that, okay? So the first order of business is to find the proper joints. Now to do that, you need to look at the ribs, and you need to either count from T12, which is the lowest rib, up, or you need to count from T1, which is the highest rib, down. And in this case, we're going to count from the lowest rib up. All right, lay still, and we're going to get started, okay? All right, so we know that this is the T12 shot. Whoops, way down there, sorry. Shot right around here. Even lower than that, here. So, oh, there. All right, I'm right over the T12 rib on the left. So that means that the pedicle there, show us the T12 pedicle, correct. 12, and then 11, and then 10, and then 9. And I need the T9 pedicle. Stay there for a second, and 12, 11, 10, 9 shot. All right, perfect, T9. So I'm right at the T9. Show us the T9 pedicle. Everyone agree? T9 pedicle, yes. And my target is exactly where the tip of my probe is, okay? Are you comfortable, sir? Yeah. All right, let's give some more numbing medicine. I'm gonna give you some more numbing medicine, okay? You might feel a little stick and burn. Please don't move. Le peau d'orange, the orange peel. You know what that happens with? Breast cancer. Is it ductal carcinoma in situ? Yeah. Le peau d'orange, the breast has that appearance of a orange peel. Okie dokie. Let's get started. Coker. Shot. All right, a little bit too medial. Shot. Any way I could see that better. 12, 11, 10, 9. I don't mean rotating, I mean zooming in. Shot. Ooh, see what, if you move it, that's what happens. I didn't want you to do that. I wanted you to zoom in, meaning move the fluoro further to the ceiling. But first find 12 again. There it is, 12, 11, 10, 9. Now come up a little bit to the ceiling. Not north, but up. Shot. Okay. Shot. Too medial. Shot. Can you see the TP? I see it below. I kind of see it there. Yeah, that's what I'm seeing. I need to be a little bit more lateral. You're doing great, by the way. Just be patient with us, okay? Shot. 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 And by the way, this procedure just requires that you make adjustments. And you're trying to get to the spot where the facet joint is innervated by a specific nerve, and that's it right there. You guys see that? I'm literally at the perfect spot. Show them. So you can see the 9 pedicle first, 9 pedicle, yes, and then the transverse process. There it is. And come back there, and that is where the transverse process, the top of the transverse process, meets with the pedicle or the superior facet. And I could feel it's exactly the right spot. So I'm going to make my incision. This procedure requires an incision, a small incision, about 3 millimeters. And once I've made my incision, I'm going to navigate my probe down to that spot where the where that target was, where I showed you where the nerve is. Shot. Too high. Shot. Too high. Shot. It's a little better right there. It could be a little lower. Shot. It's better. Shot. To medial. And by the way, as I'm doing this, I'm not actually going to the target. I'm above the target. I'm making sure my trajectory is right first. Because if your trajectory is not right, you don't want to go any deeper. If you go deeper and you're on the wrong trajectory, you're going to have problems. You're going to end up hurting the patient, doing something you shouldn't do. So you've got to be, on your AP view for facets, you've got to be lined up perfectly. That's pretty much perfect right there. So I feel the TP. I feel the bone. Shot. I want to make sure I'm in the most perfect place, which I am. And then I'm going to deliver the burn. And what you're burning in is the nerves to the facet joint. Let me just verify position. Hold on. And shot. And that's pretty darn good. So the nerve I'm talking about, folks, it's called the medial branch of the dorsal ramus. Shot. And for the thoracic spine, it's this tiny little nerve that literally innervates the facet joint, and it's responsible for all the pain that people have coming from their facet joint. So if you can eliminate that nerve, shot, by burning it, which is the standard treatment, you can actually get rid of thoracic facet pain. Yeah, you're all right. One down. Stay where you are, Jordan. I want to shot. I want to get to that point, and then we'll move the fluoro. Shot. It's looking good. Definitely on target. There's bone. Shot. That's pretty darn good. Hold on. Yep, we're there. Now while I'm here, please move your fluoro. So this should be T8, which we've marked out on the back as T8. Keep going. All right, 7, 6, 5. So let's, yeah, that looks good. But again, we're too far away. I want you to reduce the field and move that fluoro to the ceiling. Bring the fluoro to the ceiling and bring your collimator in on my side. We don't need that much long. Shot? All right, that's better. That's better. Now, any way to clean up my area that I'm at right now? Shot? I mean, just whenever you're ready, get the shot. That looks pretty damn good. Show us the top of the TP. The TP looks like a little finger. That's it right there. And where the top comes together with the, right there, right where my needle is, with the pedicle right there, exactly where the tip of the needle is, that is the most perfect spot. And we want to hit that spot on every one of these facets. If we do that, that's where this bad nerve lives. It's the pain nerve. We're broadcasting, right?
Of course.
Any questions?
Yes. We have a question from Oz on YouTube.
Yes, Oz.
They ask, what is the key difference between the traditional RFA and the Deuk plasma rhizotomy?
Yeah, it's a great question. Hold on a second, Oz, while I just get oriented. Shot. Looks good. So the key difference, there's two of them. One, with a regular RFA, the surgeon plants the tip of the RFA probe in one spot where they believe the nerve is. Then they burn. And the problem is the nerve is rarely in one spot. So when you put the needle for an RFA into that spot, you're really hoping that that is where the nerve is. But the reality is the nerve isn't always there. And so you really need to be able to move your probe. You need to move it around in the area of where the nerve is. And the RFA doesn't do that. The Deuk plasma rhizotomy does. We move around until we burn the whole area where the nerve could be. So it's around at least 20 times bigger burn area than the RFA. Shot? Okay? There you go. We're right along the top border of the TP. I could be a little more medial. I'm going to do that now. So that's number one. Number two, the actual burn is with much more powerful energy. In other words, with an RFA, it's delivering, say, an energy value of 1. With the Deuk plasma rhizotomy, we're delivering an energy value of about 10 to 20 times more than 1. So much more energy. Therefore, more effective at destroying the nerve. In the end, stay where you are, don't move, Jordan. In the end, shot. Give me a second to concentrate. Stay on top of that, please. Shot. Give me a moment just to think, and I'll answer your question. That's looking really good. See the double shadow of the TP and the rib? Show them the double shadow of the TP and the rib. There it is. Perfect. What a beautiful floral picture. This is the new florals we've been talking about. Deuk Spine just spent $300,000 on 2 new fluoro machines. Over 300 actually. Yeah, that's good. And the reason we spent so much money is because we are allergic to money. Oh, never mind. That's not why. It's because we want the very best equipment, and this is the most advanced X-ray intraoperative fluoro machine in the world in 2023. And we have 6 now of these machines that we use almost daily, and these 2 are the latest, most advanced. So they're going to give you the very best quality pictures. Do not take a picture yet. Hold on. Let me just see where we are. Hold on. Shot. All right, to north. Shot. And I'll answer your question more in a minute. It's not that I'm avoiding it. There's a reason. I just got to focus here for a second. I want to make sure I get exactly the right spot for this patient. There There it is. Beautiful. So, number one, let me just see where we are. Hold on, shot. So, number one, the Deuk plasma rhizotomy allows a wider burn area, but also more energy for the burn. The reason why the Deuk plasma rhizotomy was created, it's because we realized that the burns that we were doing with RFA, the standard burns everybody does, that they weren't lasting. And so I started to ask, why are they not lasting? What is the reason for not lasting? Why wouldn't they last? It makes no sense. And the answer became obvious to me as a neurosurgeon. There's a reason they don't last. Does anybody know what it is? I'll tell you. You're trying to destroy a nerve. Who knows better how to destroy a nerve than a neurosurgeon? The way you destroy a nerve is you cut through the connective tissue on the outside of the nerve. It's called the perineurium. And the perineurium is a membrane around the nerve that is important for maintaining or preserving the nerve anatomy. And what I mean by that, Sean, is that as long as the perineurium remains there, the nerve can grow back. The nerve can grow back. And that's what was happening. With RFAs, the nerve grows back. It grows back because the procedure doesn't cut the perineurium. It doesn't cut the connective tissue on the outside of the nerve. And because that connective tissue is still there, the nerve grows back through it in a matter of time. So the Deuk plasma rhizotomy destroys that.
Yes?
Yeah. Destroys that tube. Whereas the RFA does not. Okay? That's the reason. It works, and the RFA doesn't. And it is something we've patented. And the rest of the world is going to have to come here to train or to learn how to do the procedure. And they will, eventually. We've treated almost 50 patients now, successfully. Every single one of them, 100% of their facet pain is gone with the procedure. And again, it's just another tool we have in our toolbox for treating chronic pain. Again, the most important thing is you've got to know where the pain comes from. If you don't make the right diagnosis about the source of pain, you will never give the right treatment. And epidurals, they don't fix anything, folks. They're a waste of time, a waste of money. The only purpose for an epidural is to buy the patient some time while they're waiting for their surgery. You know, for example, if you're a teacher and you have to finish teaching, you cannot take time off to go and do surgery. You need to teach your students until semester's over. Shot, don't move around, you're fine. All right, so just about done here with this one. Luis, we have one more?
Yes, sir. 5.
Huh?
Yeah, 5.
All right, so we've done 4 nerves, 4 out of 5. Got one more to go. All right, everybody, stay, let's see. We've got to target that last spot. Don't move your fluoro, don't turn it on. Just put some pressure for a second. I don't want any bleeding. Don't take a picture yet, I'll tell you when. Watch your fingers, Luis. Now, shot. Something moved, right? Did you move the floor, or maybe the patient moved? Sean? Well, it's a good thing I have a good memory. Sean? All right. Almost there. Let me just finish. The key here, folks, is if you're doing these procedures, whether you're doing an RFA or a DPR, you have to be on the bone. If you are not touching the transverse process, you are not going to get a good result. Sean? Yeah, and we're on the TP right there. Sean, I moved it up a little bit. I'll move it a little bit more up. Right there, Sean. That's as perfect as it gets. Go ahead. I'm going to put a little num-num. I need a knife. I'm using an 11 blade to make a 3mm incision. That should be our last one. Now, for those of you thinking about doing this, you have to be very careful. Okay? It may seem like an easy procedure to do, but it's not. Shot. It's easy to get in trouble, but it's not easy to do it properly. It takes training, it takes experience, both of which I have a lot of as a neurosurgeon, 26 years of operating on spines. You got to know the anatomy. My most important teacher in my entire career, besides my father, was Dr. Roten, Albert Roten, who is the father of neuroanatomy. And Dr. Roten built the most important training program in the United States for neurosurgeons at University of Florida in Gainesville. He was the one who's responsible mostly for the Brain Institute, which is I think it's now called the Knight Brain Institute. Anyway, Dr. Roten believed the most important skill to have was a commanding understanding of anatomy, neuroanatomy. He said a neurosurgeon cannot properly treat a patient without understanding neuroanatomy, and he's right. And that's why he selected me. I was a neuroanatomist. I was a top neuroanatomist in the country, as a matter of fact. Back in '96, I won the Retzius Neuroanatomy Award in Los Angeles, which was given to the person who scored the highest on a national test given once a year at Children's Hospital of Los Angeles by Dr. Floyd Gillis and his team. And I scored a 49 out of 50. The second highest scorer was a neurosurgeon at USC, and he scored a 35 out of 50. He got 15 wrong. To show you how hard it was, I got one wrong, one question wrong. I had the highest score they've ever had. So my neuroanatomy is very good. My basis of neuroscience is in neuroanatomy, and that's why Dr. Roten liked me. That's why he selected me to join his program. We took 2 residents every year. One was, my year was Dr. Tolentino, Paul Tolentino from Harvard, and then myself from USC in Los Angeles for neurosurgery training. It's a 7-year commitment to the training program. Anyway, I believe, and I've used my foundation in neuroanatomy as the basis of my success in what I do in spine surgery. By understanding the anatomy of the spine, where the nerves are, where the spinal cord is, where the holes are, where the joints are, I use that to do really good treatments, surgical treatments. So what I would say to anybody that wants to be great at anything, be a good anatomist. Learn from Dr. Roten's priorities. All right, any questions?
No current questions. We have a comment from Canes25 on YouTube saying, "Sir, it looks like money well spent. Extraordinary images, so crisp and clear.
Yes.
I love the way you're always looking to enhance the patient's care and your passion for it."
Thank you. Yeah, we're all that way here at Deuk Spine. All my employees are the same way. We all care about quality. You can see the small incisions. Let's show them. You guys see them?
Yes, we do.
They're 3 millimeters each. We had to do 3 of them. And with each one, I can treat 2 nerves. So we did 5 nerves with 3 incisions. I think he's going to be very satisfied, I think, with the results. All right, well, thanks for joining us. We're going to end the broadcast. We'll be back Thursday for more surgery.